Visual field defect. General features. Is the patient thin and pale with waxy skin, suggesting panhypopituitarism, or does he have features of acromegaly? Does he have signs of a previous stroke, facial asymmetry, upper limb held flexed and internally rotated and a lower limb extended? Are there any aids for those with visual impairment present, white stick, magnifying glass or braille books beside the bed? Examination of vision. NB. In determining the site of the lesion, it is important to decide whether the visual field defect affects one or both eyes. Monocular field defects. Visual field defects affecting one eye only are due to lesions in the visual pathway anterior to the optic chiasm, either within the eye or in the optic nerve. A central or paracentral scotoma, loss of the visual field within or adjacent to the central area of vision, usually indicates damage to the macular photoreceptors, e.g. macular degeneration, or macular nerve fibers at or within the optic nerve, e.g. optic neuritis. It is important to look for associated features such as reduced visual acuity, color desaturation, and a relative afferent pupillary defect. Is there papilloedema suggesting a local compressive lesion, such as optic nerve glioma? A dumbbell-shaped scotoma that covers both the central visual field and the blind spot is termed a secocentral scotoma, which strongly implies optic nerve pathology. It is occasionally difficult to distinguish between an enlarged blind spot and a paracentral scotoma. Fundoscopy will reveal an abnormality of the optic disc, e.g. drusen, or papilloedema, in the case of an enlarged blind spot. Horizontal/altitudinal field defects extend to the periphery but do not cross the horizontal midline. They most commonly occur in anterior ischemic optic neuropathy due to vascular disease or giant cell arteritis. A monocular segmental defect, for example a quadrantanopia in one eye only, may be due to retinal disease, such as ischemia from a retinal artery branch occlusion of retinal detachment. Careful fundoscopy of the dilated eye is usually diagnostic. Binocular field defects. Field defects affecting both eyes may be due to bilateral ocular pathology, e.g. glaucoma, or macular degeneration, or bilateral optic nerve pathology, e.g. due to toxins or multiple sclerosis. More frequently, however, binocular field loss is due to chiasmal or retrochiasmal lesions. Does the field defect respect the vertical midline? If so, the lesion is either chiasmal, bitemporal hemianopia, or retrochiasmal, homonymous hemianopia. Chiasmal lesions will eventually progress to involve the other visual field if left untreated. If the field defect crosses the vertical midline in each eye, the lesion must be anterior to the optic chiasm, indicating either ocular or optic nerve pathology. Bitemporal hemianopsia, B, are seen in lesions affecting the optic chiasm. NB. Typically, pituitary lesions expand upwards into the optic chiasm resulting in a predominantly superior bitemporal hemianopia. Hypothalamic lesions expand downwards resulting in a bitemporal hemianopia that is most dense inferiorly. Lesions within the optic tract, optic radiation, or striate, occipital, cortex cause homonymous visual field defects. These are typically hemianopic, C, although quadrantanopias, D, are seen in focal lesions within the temporal lobe, superior quadrants affected, or parietal lobe, inferior quadrants affected. The field defects tend to become more congruous, i.e. become more similar in each eye, the more posterior the lesion. Macular-sparing homonymous field defects implicate the striate cortex, E, which is commonly affected in a posterior circulation ischemic event. The occipital pole, which is important in resolving the macular visual field, may additionally receive some blood supply from the middle cerebral artery. Other examination. Once the characteristics of the visual field have been elucidated, it may be important to extend the clinical examination outside the visual system. If a pituitary lesion is suspected, look for features of acromegaly or panhypopituitarism. Other signs of multiple sclerosis should be sought in a young patient with signs of optic neuropathy, reduced visual acuity, a central scotoma, reduced color appreciation and a relative afferent pupillary defect. Look for ataxia and spastic paraparesis, etc. Check the vascular status in a patient with a homonymous hemianopic visual field defect. Look for signs of coexistent hemiparesis or hemisensory loss. Are there any cortical parietal signs such as dyslexia, dyscalculia, or dyspraxia? NB. In patients with monocular visual loss, check the carotid arteries for bruits, auscultate the heart for murmurs and feel the pulse for atrial fibrillation. Palpate the temporal arteries looking for tenderness, suggesting giant cell arteritis. Check the inflammatory markers, particularly in any patient over the age of 50 years. Further discussion. What are the possible causes of optic neuropathy?